يلا السلام عليكم ورحمة الله وبركاته. Good morning everybody. Today we're going to talk about infection control in healthcare. Of course, infection control is extremely important because basically you're trying to protect the safety and well-being of the patients as well as the healthcare workers and the visitors who are visiting the healthcare facility. So you have a very tough job ahead of you as a person in charge of infection control. So what we'll try to learn today in 1 hour is define infection control and then understand the transmission of pathogens, talk about the chain of disease transmission, and then how do we prevent disease transmission by applying standard precautions in general for everything in dealing with patients in the healthcare facilities. And then when we have patients who are infectious, what kind of specific transmission-based precautions we can use. We'll also talk about sharp injuries because it's something that is extremely common in healthcare facilities. Unfortunately, there is significant underreporting. Okay, so healthcare workers, including medical students, intern, residents, nurses, they're all afraid to report needle stick injuries. They have it and they stay quiet because they're afraid they're going to be punished, they're going to be disciplined, it's going to cause them issues and concerns, although there's a risk of disease transmission, which is going to be impacting their livelihood and also their family health. And then talk briefly about disinfection and sterilization and what is the difference between both of these things. So infection control is really critical. There is no healthcare facility that operates under Sibahi in the country without a good infection control program. And there are standards they're supposed to be following under Sibahi. These standards are updated every 2 years and basically talks about every level of the organization. The role of the leadership, the management of the institution, the reporting mechanism between infection control and the highest level of the organization. And then it talks about what kind of staffing requirements and what kind of activities they're supposed to be doing and what kind of infection rates they're supposed to monitor. And then they report this to the Ministry of Health in Saudi. In other countries, they report to the CDC. In the UK, they report to the NHSN. In every country, there is a mechanism of reporting and monitoring. وزارة الصحة, Ministry of Health, has a department for infection prevention and control, which is under Wiqaya now. And their role is to receive these infection rates and then decide if they are acceptable or if there's a problem. So basically, these infection control standards apply to healthcare facilities, to primary healthcare centers, to long-term facilities, and also to the community setting. And its primary goal is to protect patients, healthcare workers, and visitors, and hopefully reducing healthcare-associated infections, morbidity, mortality, and also reducing cost. So why does it matter? Of course, you're trying to avoid harm. You don't want somebody to come in with, a minor thing and then come out with a severe infection. So you want to make sure that they stay healthy while they're there, reducing the healthcare-associated infection, and also protect the vulnerable patients who are immunocompromised. You have patients who are oncology patients who are on steroids, on immunosuppressants, that are at increased risk of having infections that are severe and can cause morbidity and mortality. These are different infectious agents, and these infectious agents tend to stick on these environmental issues. So they stick on bed rails, on bed sheets, on the table where the patient is eating, everywhere in the environment, as well as on the equipment. So the IV pole, everything in the room could be contaminated. And also we as healthcare workers, nurses, physicians, RT, occupational therapists, when we deal with patients without good practices, we can acquire the organisms, and if we don't do hand hygiene, we can transmit the pathogens to others. So this is the chain of infection that is basics of infection control, and this is from the CDC. It talks about the microorganism. We've said all kinds of microorganisms, fungi, bacteria, viruses, parasites. They are actually stuck on the reservoir, and this could be a human, equipment, or whatever. And then these pathogens exit the body of the patient either through coughing, sneezing, sputum, through excreta, urine, stool, and then basically there's a mode of transport. So the organism sticks on something and then you come and contaminate yourself. From there, it goes into the human body of the employee or the healthcare worker, and then basically causes an infection, and then it can spread the organism across different organizations. So this sort of explains in more depth the different steps of the chain of infection, and this is ABC of infection control. So there's nobody who's working in infection control that does not understand the chain of infection and how it operates, because if you comprehend this, then you can always be cautious on trying to prevent the spread of infectious disease. So how do you prevent the disease from being acquired by a healthcare worker? Good hand hygiene. It's easy to say, and we promote hand hygiene in healthcare facilities. I worked in infection control for many years in the National Guard and Security Forces Hospital and the military, and it's extremely difficult to have people apply these recommendations, especially physicians. For some reason, we feel that we are above everybody else, and we don't think that the pathogens will come to us. So when we go to the room, we don't clean our hands. When we leave the room, we don't clean our hands. And if the nurse dares to say to the physician, why have not you used hand hygiene, the physicians get very upset. So our role as infection control is to sit in the nursing station and monitor, to see the compliance. And if a physician becomes abusive or does not follow recommendations, we go and talk to the physician and say, this is for your own safety. And if there is any issues, we raise it to the CEO of the organization. So we have to support the healthcare workers in trying to apply hand hygiene. PPE used, personal protective equipment, is very critical, and I'll go through the details. And that for you is, if you learn one thing from this lecture today, is how to put on PPEs and how to take them off. So this is like top priority for you, because this is how you're going to prevent yourself from acquiring infections in the healthcare facility. Of course, cleaning the environment is very important, and then isolating patients who are at high risk of exposing healthcare workers to infectious disease. So in healthcare setting, there are at least 4 common healthcare associated infections that we monitor. It's mandatory. So if you go to Shumaisi, if you go to KFMC, if you go to King Faisal, if you go to King Fahd Medical City, any institution in the country, they have to monitor these infections, and they're monitored in critical care areas. So they monitor CAUTI, catheter-associated UTI, CLABSI, central line associated bloodstream infection, surgical site infections, and ventilator-associated pneumonia. And the commonest of all these infections are UTIs. So UTI is by far the most common. Almost every single patient that goes to the hospital, they stick a Foley catheter in. And most of the time, it's not indicated. And I can tell you, the nurses fight to have a catheter in the patient. The reason is, it's much easier for them to monitor the ins and outs. So if the patient does not have a catheter, she cannot tell you how much the patient voided. The patient has to tell her, I'm going to go to the washroom, I want to pass urine, and then she has to go and ask him to pee in a container so that she can measure and document in her chart. But when he has a catheter, it's easy. She can sit at her desk and then come every 6 hours, look at the catheter container, and so we used to fight with the nurses, not because they're not doing a good job, but because they prefer to put catheters inappropriately in patients to make it easier for them to handle the patients. So I'm going to go through some of these infections in depth so that at least you're aware of what they mean and their significance and how can you prevent them. So as I said, most of the patients who go in to the hospital, they get a catheter put in, and this is usually done by the nurses pressuring the interns and residents. We need to have a catheter in this patient. It's very difficult to, doctor, please. Resident يقول لك يلا, حط the catheter. So it's the responsibility of the most senior person in the team when they go on rounds to say, Does the patient have any foreign bodies? And if he sees a Foley catheter, what is the indication? Okay? If there is no indication, catheter comes out. Okay? So as I said, cavity is the most common infection. Once you put a foreign body in the urine, it's almost, absolutely is going to be infected. Just give it time. And then the longer the catheter is in place, the higher the chance of having a cavity. And of course, yes.
Sorry for cutting you off. We also learned that when you want to insert a Foley catheter, it's absolutely indicated. You also need to make sure that it's changed out on a regular basis. Do you think that's an issue that we also have, or is this left, or is that good? Like class, we don't need to worry about?
We don't need to. There's no recommendations on changing the Foley catheters. Okay, so Foley catheters are only inserted when they are required, and they are removed as soon as you don't think that they are required anymore. Okay, you don't need to, unless the patient has an infection and you give antibiotics and the infection is not going away, then you ask them to remove the catheter and put a new one in, because sometimes the bugs stick on the catheter itself, on the material, the latex of the catheter material. And this is basically a diagram showing how we insert the catheter and then we blow up the balloon with sterile fluid so that it sticks into the bladder. And then basically the ports, this round blue thing shows you the main port where the urine goes through, and then the smaller port where you actually take samples to send for cultures and sensitivity. And the bag, always remember, sometimes the nurses put the bag on the bed. Not acceptable. Okay, it has to be on the side of the bed so that it's lower than the patient, so the flow is continuous. You don't want to have any stagnant urine staying in the patient area. So these are the key principles. Avoid catheter use, and believe me, if you focus on it, you'll be amazed. When I used to do rounds, I removed 60% of the catheters. يقول دكتور ايش قاعد تسوي؟ أول ما أخش, does this patient require a catheter? أنت تقدر تقوم تروح الحمام? Can you use the container? And if they say yes, the urinal, take it out. Now, طبعا the nurses don't like it, as I said, بس إنه you have to do it, otherwise هيصير عندك الكاوتي rate extremely high, and then you will cause significant damage to the patient, morbidity and mortality. طبعا the insertion process has to be very proper. You cannot just, we have specific guidelines for nurses, and we have training for nurses to how to insert the catheters, the way they have to clean the area, the way they insert, it has to be very sterile, and it cannot be done sort of quickly and haphazard. And then you have to maintain and take care of the catheter by having it always clean, having it always on the side of the patient and not on the top of the bed. And then of course, whenever you think the patient is able to pass the urine in a urinal or in a pad, or he can go to the bathroom, please remove the Foley catheter. Of course, if you have a UTI, you will have an increased risk of complications, not only from infection, but also because if you are a patient and you're stuck with a catheter inside your body, it will make it difficult for you to mobilize. فيجي لك clots in your legs, you'll have issues with muscles being weak, because you're stuck in the bed. You cannot move around with the Foley catheter hanging, and even having an IV catheter. So it makes it more difficult. So you can have clots, you can have emboli, you can have many other complications, and you can have issues hematoma in the bladder, many issues that can cause damage. So as an infection control person, when you're collecting data on cavity, you have to go around and see how many patients have catheters, how long has the catheters been there, and then if they have an infection documented by fever and increased white cells and also increased bacteria in the urine, and the catheter has been there for 2 days, then that qualifies to be a cavity. Okay? Anything less than that is not a cavity. Okay? So this is a diagram that shows you easily how you can do the calculation of your cavity rates in the hospital. If it's less than 1 day, it does not count as a cavity. Okay? Surgical site infection, that's something that we struggle with as surgeons, and I know some of you will be surgeons when you grow up, and surgeons are the most difficult people to deal with when it comes to infection control, because they don't listen to recommendations. They think they know it all, and sometimes they don't admit that the patient have a surgical site infection. So one of the criteria for you to diagnose a surgical site infection is for the surgeon to call it infected. Okay? So the surgeon has to say this wound is infected. وهذا بالنسبة له يعني خط أحمر. لا يا شيخ كويس يعني it's not infected. So I think you have to be very consistent in documenting your surgical site infections. And yes, you can say it does reflect on your practices. So a good surgeon should have a very low surgical infection rate. A bad surgeon will have a lot of infections. Okay? So we in the National Guard, we used to report surgeon-specific infection rates. And those rates go to the CEO confidentially. They go to the surgeon, but they also go to the CEO saying these are the list of surgeons, these are the list of procedures, and these are the infection rates. So if you have somebody who has 20% infection rates and you have somebody who has less than 1% infection rate, you can tell who's doing a good job and who's clumsy and who's not doing a great job. Okay, طبعا if there's any surgeons here هيعصبوا عليه, لكن this is facts. Okay, so basically when we look at wounds, this is very important. This is the skin. So you have the superficial, subcutaneous, and you have deep, and you have organ space. Okay, and the reason we have this picture all the time when we are defining surgical site infection, because when you're calling a surgical site infection, you have to specify: is it superficial incisional infection, or is it deep incisional infection, or is it actually organ space? And for each one of them, there are criteria. Okay. Unfortunately, sometimes patients leave the hospital very early. Okay, now this is part of the quality improvement, that the patients don't stay in the hospital for too long. Well, infection usually within 30 days of the procedure. So if the patient leaves within 2 or 3 days and he goes home and the wound becomes infected, you will not know unless the patient comes back to the same surgeon. So this only happens when you have a population-based healthcare facility, i.e. National Guard, military, security forces, where they have their own catchment area. But if you go to a private, أنا اليوم أروح الحبيب، بكرة أروح الفقيه، بعد بكرة أروح دلة, next day I go to another facility. But then you will actually have a lower rate of infection because you're not catching all the surgical infections, unless you do post-discharge follow-up. So in some good institutions, when the patient is discharged, a week later, you get a call from the nurses saying, how is your wound? Is it red? Is there any pus? Is it inflamed? Is it painful? And if they say yes to any of these questions, then you ask them to come in. So you can take a swab and you can document that the wound is infected. Otherwise, you hope that the patient will come back to the same facility and the surgeon will be good enough to sort of suspect that this is infected and take a swab. If he doesn't do that and he gives the patient antibiotic, you as an infection control person will not know that this is an infected wound. So this is another trick that the surgeons play. They look at the wound and they say, looks infected. بس الحين لو أخذت مسحة, the lab will show the results. So they give the patient antibiotic. The only way we can monitor is by going through the lab results and looking for wounds. So all these tricks you learn as you practice infection control and you deal with different specialties. And of course, the level of infection is really important, whether it's superficial, deep, or actually organ space, because when it's organ space, it's actually inside the abdomen, but it causes an abscess and a collection that needs to be physically drained. These are some of the measures that you should apply to prevent infection. One of the most important measures that we always fight with the surgeon is antimicrobial prophylaxis. Okay? So anybody who's going for a procedure has to get an antimicrobial prophylaxis. This prophylaxis has to be given 60 minutes before the procedure. Okay? An hour before the procedure. So what happens 90% of the time, يقول لك احنا اعطينا antimicrobial prophylaxis. Patient is in the ward, يعطوا له antimicrobial prophylaxis, يزهمون العمليات بعد 3 ساعات. Useless. Okay? You want the antibiotic to be circulating in the blood stream when the patient is doing when the surgeon is doing the surgery, so that you can prevent infection. But if it's not there anymore, because it's lagged 3, 5, 4 hours, then there's no point. Some mechanisms that we apply, and we give the antibiotic in the OR, an anesthetist يعطيها, أو in the pre-op area where they take them to the pre-op area to sort of check them and before they go, and they give the antibiotic just before they walk into the room. Okay, so this is the most important because it's the most effective way of preventing surgical site infection. Central line, also very critical because again, most patients who go into the hospitals, they have a line in place, whether it's a peripheral IV or a central line. The central line could be internal jugular, it could be subclavian, it could be femoral. The peripheral could be anywhere on the arms and also on the legs, and they all can get infected. Peripheral lines that are put in the ER should be changed when the patient go to the ward, okay? Because they are pushed in a rush, and you worry that they get infected. So when they come to the ward, you remove them and you put a new one in so that you do it properly. Okay, so source of the infection for the line could be from the insertion site, i.e. skin organisms on the site where the insertion happens. It could be from a bloodstream infection that sticks to the catheter. Could be from the infusate, which is less likely. The most common is actually from skin organisms at the site of entry. And there are many factors that tend to increase the risk of infection, especially if the patient is older, if the patient is immunocompromised, if they have received antibiotics, they'll be colonized with a lot of resistant organisms. And then if you don't do proper cleaning and you insert the line, then you can contaminate the line as it goes in. It's very simple. In trying to prevent the central line from getting infected, you have to choose the best site, and each site has advantage and disadvantage. Okay? You want a central line because it's easier, it's wide pore, you can pour blood, you can pour TPN, you can pour fluids, ما عندك مشكلة. Peripheral, it's actually very limited. If you give too much fluid, it blows up and you have to change it and replace it, but also has a risk. So the site of the selection is important. For central line, the best is actually to do a subclavian. Femoral line is not good because the area is always dirty and sweaty. And then this area, because the neck is always bending for the patient, it gets sweaty and it gets infected. This one is exposed. Okay? فلما تحط اللاين وتغطيه, it's very dry. So this is the best site for having a central line. نوع الcatheter is also important. Now there are many technologies for best catheters, but you have no choice because you are a healthcare worker, you are in a facility. Facilities كلها تاخذ catheters من NIBCO as a central procurement for catheters. So whatever they get is probably the best in the market. Technique is important. You know, you have to have a good hygiene and sterile environment when you insert it. ما ينفع كده تحط اللاين كده لا. You have to sort of do the proper preparation. You have to have the sterile gloves. Yes.
But it's not an aseptic technique, so it's fine if we don't wear like the gloves that are required.
لا, for central line insertion, yes, you have to be aseptic technique. Yes. So basically, what you do is you have to properly clean the area, providing iodine and the alcohol, and then you cover the area well, even covering the head of the patient and the body if you're doing it here. And then the person wears gown, wears sterile gloves and mask, and then does the procedure. And when he's done, he can get rid of the stuff. Ventilator-associated pneumonia, again, patients who are ventilated, they tend to get pneumonia. And of course, there are many reasons why they get pneumonia. Is because you're basically blocking their reflex mechanisms to cough and bring things up and secretions up. So basically, you put a tube in, so you paralyze their natural mechanisms. So all the secretions in the mouth can go into the lungs and cause an infection, especially if the person is colonized with a multi-drug resistant organisms or fungi or whatever because of his natural status. And of course, if the patient is sedated, then he's completely out. He cannot control anyway the mechanism of getting rid of the secretion. You always have to put the head of the bed slightly up so that at least you prevent the secretions from going into the lung. And you use ETT cuff, so when you put the tube, you inflate الهواء اللي حول التيوب حتى ما يصير في secretions تنزل on the lungs. Of course, for the pneumonia to happen, there are many risk factors, and there are many things that we recommend to the nurses to do while they're dealing with these patients to prevent the VAP from happening. Okay, so we recommend that they inflate the cuff. We recommend that they keep the head of the patient up. We recommend that they actually clean the mouth on a continuous basis with chlorhexidine, whatever. عندنا swabs كده تلاقي عليها كورة بيضة فيها chlorhexidine. You just wipe the mouth, so if there's any organisms, you can actually clean them out. And then you can use special mechanisms in the ventilator to sort of reduce the infection rate. Try as much as possible not to put the patient completely out. Okay? Sedation mild, so at least he can يعني يحس على نفسه شوية. Supine position. Of course, if you're older, if you have comorbidity, if you have a smoking history, basically you are at increased risk of having infection. So preventive mechanisms, these are the common strategies that we sort of apply, whether oropharyngeal colonization, things that decrease the gastrointestinal colonization, and also you don't want to have any biofilm on the ET tube itself, because that will be a source of a continuous seeding into the lungs. Okay? And these are some of the measures that can be used. So this we ask the RT, the respiratory therapist, to help us in adjusting the ventilator mechanism so it can actually reduce the VAP rate among the patients. Okay, so these are the common infections, and what happens at the end of the day is each hospital collect their own data and they post it and they send it to the Ministry of Health, and the Ministry of Health puts KFMC, شميسي, تخصصي, حرس, العسكري, دلة, حبيب, and then they say, oh, شوفوا أنتوا في KFMC, you're not doing well, you're يعني BSI rate حقتكم مرة عالية, في عندكم مشكلة. أو مثلا الVAP حقتكم, your VAP rate is higher than the other facilities. So the Ministry of Health puts a benchmark. This benchmark, you should be less than as an institution. And you should do a lot of effort in your institution to be able to reduce these infections and compare yourself to other facilities. So this is what we do, is at the end of each month or each 3 months, we produce a graphic of what the rates are, and we send it to the chairman of the department and also to the CEO of the hospital.
How do you ensure that everything is properly reported?
You have to be a smart investigator. So we have our spies everywhere. So infection control director, انت yourself can actually see. أنا when I go and do a consult في ICU تلاقيني قاعد على الطاولة أكتب الكونسلت حقتي على الديسك وقاعد أشوف إيش بيصير. Somebody, a physician comes in, opens the door and walks into the patient room. What the hell is going on? This is unacceptable. So I stand up and I go and I say, Doctor, this is not right. Yani, there's alcohol rub. You're supposed to use the alcohol before you go in. This patient is in isolation. You're supposed to put the stuff on. This is a function of the nurses. But our problem for Saudi, which is different than Canada and the US and Europe, is the nurses are afraid of the physicians. Okay, so you have to be a physician to stand up to a physician. Okay, so they get very, happy when they see the physician goes to the colleague and say, please, do this. Because if a nurse goes to him, he'll basically give her a hard time. Okay, so it is your role as a physician to be helping the patient to get better, and I talked about the surgeons and how they want to hide the surgical site, and I also talked about the nurses when they're trying to reduce the rates of nosocomial infection. Sometimes they give you a different denominator. They play with the data, so you have to be physically there. So as an infection control department, you have to have one person assigned full-time in the ICU. His function is to monitor and to ensure that the surveillance data being collected is accurate. Okay, so double check.
This person from the ministry,
Yeah,
from the
From the institution. Each institution has to have an infection control program. Okay, this program is a leadership program. Zero quality is separate, infection control is separate. This program reports to the highest authority in the organization. The reason is because you want to have influence. Okay, if you are reporting to somebody junior from Mustashfa, nobody's going to listen to you. But when you are reporting to the CEO, everybody's afraid. That's why when I go to the ICU, كل الناس يمشوا كذا 100 تلاقي الكحول بس نص ساعة. You leave the ICU, everything goes back to normal routine. So this is really important. It's important to understand the mode of transmission of the disease if you want to make sure that you understand the transmission and how you prevent it. So for dealing with all patients in the hospital, you use universal precaution. And I'll tell you what universal precaution is all about. But for certain diseases, you have to use transmission-based precaution, which i.e. means depending on the type of the organism. So you can use, there's only 3 mechanisms: contact, airborne, and droplet. Okay? And the difference between the airborne and droplet is that airborne requires N95, while droplet requires just a regular surgical mask. Okay? The contact طبعا, you wear a gown and you wear a glove because you don't want to have any physical contact with the patient or the environment of the patient. Okay? Airborne, you want to make sure you don't get TB or measles or some of the infectious diseases that are transmitted through aerosols, so you wear N95. Droplet is like mumps, like influenza, like other things that can spread with a larger droplet, not a small aerosols. So this is the standard precaution. This is something that you should be using most of the time when you're dealing with patient. You should be applying hand hygiene. You should be wearing personal protective equipment when required. You should be using respiratory hygiene or etiquette. Respiratory hygiene, when you're walking in the hospital, suddenly you're sneezing, so you don't do that. Okay, this is unacceptable. So you have to basically either wear a mask or use your arm to prevent the spread of the aerosols. And you can see that here in the cough etiquette. You'll be surprised what you see in the healthcare facilities, and especially if you're in the lounge or in the cafeteria. People just cough and sneeze and عادي جدا يعني. So you have to come up and tell them this is unacceptable. You have to cover your nose or cover your mouth. Sharp containers, you have to utilize them properly. If there's sharps, you have to put them in the right place. And you have to dispose of the sharp containers properly when they're 2/3 full. You don't wait till the needles are sticking out of the sharp boxes before you change them. This is unacceptable. And that's the responsibility of the nursing staff. And also cleaning the environment is really critical. Hand hygiene, all of you know the 5 moments, حق hand hygiene. This is ABC practices where you're supposed to basically use hand hygiene to prevent the transmission of disease from you to the patient and also from the patient to yourself. In Europe, North America, and now, alhamdulillah, in our country, you see patients who are very vocal. Okay? The patients, the physicians and the nurses who go in and suddenly start playing with the monitor, and the patient says, "What are you doing? You know, did you use alcohol? You know, you're supposed to wear a glove." So people are being more aware of nosocomial transmission, which is important. So this is your role to educate people, educate your family, educate your relatives that, you know, you do not want to get infected when you're in the healthcare facility because of somebody's failure or malpractice. Hand hygiene is important. Compliance extremely poor. The acceptable compliance rate is 80%. Anything less than 80% is unacceptable. So you have to work very hard by having monitoring system. And what we do is, I said, we have ICPs sit in different clinical areas, and they pretend they're doing something different, and they just monitor and see how many percentage of people who are entering rooms are actually applying hand hygiene. And we document this, and at the end of each month, we give statistics. So nurses, physicians, RT, occupational therapists, so on and so forth. We talked about respiratory hygiene. Contact precautions we talked about is we want to prevent your body and anything that will be close to the patient from getting contaminated. So the gown, in case you come to the bed rail and it's contaminated, the gloves, so that if you touch anything, and then the mask so that nothing comes on your... Droplet is surgical mask, and airborne is N95, okay? These are the PPEs, and again, as I said, if there's one thing you need to learn is how to put on and take off PPEs. Okay, if you don't know that, you're in deep trouble. Okay, so I don't know if you know, but in healthcare facilities we have a program online that all the physicians have to get certified that they have gone through infection control training, and part of it stresses the issue of when you're putting on, what do you put first, and when you take off, what do you take off first, and this is really critical.
Is this program available for the students?
والله أنا I think it is. بس at least في الشميسي you go in on the website of the facility and then it tells you training programs, and then you can actually log in with your لا يحتاج اليوزر name والpassword to log in. So maybe when you are working in the healthcare facilities you can actually
Not as a student.
not as a student, no, unless they give you username and password. Again, these you have to memorize the way that you put things on and off. It's really important, and you get asked about it quite frequently. Okay, now injection practices. This is really important. You know, most of the medical students who are doing surgical rotations, they like to sort of do closing, and they like to sort of do stitches. And if they're not very well experienced and how to handle the needle, they can get stuck with the needle. Okay, so it depends on the patient. If the patient has hepatitis C or hepatitis B and you're not immune, then this is a problem. And if the patient has HIV, it's a problem. So it's a whole process. Each hospital has its own policy for handling needle stick injuries. The most important thing is the first thing you do is you take off your gloves, you go to the sink, you wash your hand with soap and water, and then basically you try to squeeze the blood out if there's any blood coming out, so that you don't have anything goes back into your body. And then you go to the employee health to report it. If it's after hours or during weekends, you go to the emergency room. Okay, and the emergency room has their policy on what to do with the patient and also with you as a healthcare worker. So these are some of the facts. Who gets the most needle stick injuries? Nurses, because there are a lot of nurses in the healthcare facility compared to physicians and to other staff. And then, you know, where do they get the injuries, and you know, how important it is. It's really critical. And I think this is also the items that you tend to use most that tend to cause needle stick injuries. Okay, so scalpels if you're in the OR. And then, of course, the syringes, needles, suture needles, as I said, is very common. Okay, and these are the ones that the surgical team, the professor or the surgeon says, you know, you're a good boy, I'm gonna ask you to close the wound, and then you basically تاخذ معاه هدية. So this is really important. Of course, environmental cleaning is really critical. Without having proper environmental cleaning, you can have major contamination and spread of organisms. We talked about this. You know that for certain patients we have negative pressure room and positive pressure room. A negative pressure room, when you open the door of the patient, air gets sucked in. Okay? So if you have a TB patient and you don't want any of the the air that's contaminated to go out, every time the door is open, the air is actually sucked in. So there's no air going outside. Positive pressure is if you have an immunocompromised patient and you want the air to go out. Okay, so you don't want anything to come from the outside into the patient room. So every time you open the door, it's a positive pressure, so the air goes outside. Okay, examples. So you have a patient with TB who comes into the hospital through the ER, and they call you, you're the student on call, and they say, Doctora, we want your opinion where to put the patient. So where are you going to put the patient? And what recommendation would you put for that patient? Okay, so what do you call it? Airborne. Okay, so TB patient, measles, most infectious pathogen measles is a virus that spreads very quickly. Airborne transmission and negative pressure room. It's a must. Okay. C. difficile. C. difficile is what? زي ال MRSA, زي ال MDROs, زي ال gram negatives. Contact. Okay, you don't want it basically transmits through contact. So the patient has diarrhea, he's basically contaminated the environment. You want to have a contact, it's not going to spread through the air. Okay, C. difficile is a stool pathogen. Okay, so contact precautions. Okay, so the last part is the issue of sterilization, disinfection. When you talk about sterilization, you want to make sure that the item is completely sterile, i.e. there is not a single pathogen there, whether it's in spore form or in live form. Okay, disinfection is you're cleaning. Sometimes there might be some stuff left on the item, and this is basically a breakdown of what sterilization and disinfection means. So basically, you have high-level disinfection, intermediate-level disinfection, you have low-level disinfection. This is really not that critical because it's not something that we care about as physicians. It's for the CSSD people, Central Sterile Supply Department, and also the infection control they take care of. But you need to know that sterilization is really complete elimination of the pathogen, even in spore form. And the disinfection has 3 levels of accuracy. So to do sterilization, you can use autoclave, you can use ethylene oxide, and all these new technologies that are being used for sterilization. And disinfection, you use alcohol, chlorine, and quaternary ammonium, and many of these other products. And of course, you need to know what Spalding classification is. This is like the ABC of CSSD. You cannot be infectious disease or infection control and not know the Spalding classification. This is basically classifying the items that you are using at different levels depending on where the item is going to be going. Okay? So if the item is going to be touching the skin, it's not that important. But if the item is going to go inside the patient's body or inside the patient's vessels or inside the urethra, this is critical item. Okay? So it's important to identify the level of criticality of the item that you are using. So when do the system fail for sterilization? If you are overloading the system or if you are using incorrect temperature. Again, this is not your responsibility as a physician. This is the CSSD responsibility. But we as infection control, we oversee CSSD. Okay, so CSSD, yes, independent under nursing, but we as infection control department, we oversee the role and function of the CSSD to ensure they're doing a good job. Of course, when you have an outbreak, then you have to start an investigation, and this is really, you have to start basically documenting that there is an outbreak. Is it true or is it not true? And then you have to look at the reasons why this outbreak is happening, and then generate a theory of what is the reason. So basically, you see an increased rate of gram-negative bacteremia in the ICU. You go, why would they have gram-negative bacteremia? So you start thinking, is it from the central lines? So you look at the patients, how many of them had central lines? Only 5 out of 100. So it can't be central line. Okay. What else that is commonly used for all the patients? Oh, they use alcohol. Maybe the alcohol is contaminated. You take some of the alcohol, you culture it, and you see if there's anything growing in there. What else are they using in common? And then, is there one staff that is caring for all of them? يطلع مثلا واحد ممرض ولا واحد physician, he's the one. You go and swab his hand, swab his nose, swab his throat. So this is how it works. It's like Columbus, okay? When there's a criminal act, you're supposed to go and investigate, and you use hypotheses, and then the hypotheses, you put them into 1, 2, 3, 4, 5, and every time you eliminate or, add more theories on the reason why the outbreak is happening. It's a very great work, actually. It makes it challenging, and sometimes it takes you weeks before you figure out what the reason is. But it takes a lot of work. I think with that, I will, of course, we talked about the reporting system. Depending on the country, we report to the Ministry of Health, or now I think it's Wuqaya, no longer the Ministry of Health. And then, of course, other countries report to CDC, Public Health England, NHSN, and so on and so forth, depending on what the regulations are in each country. But for us, it's Wuqaya. So with that, I would stop, and we have a few minutes for questions, if you have any questions or comments.
I worry about that since we use alcohol gloves a lot, the common pathogens that are on your hands, would it be worried that they get resistant to, they find mechanisms to just not get killed by alcohol?
It's possible, and that's why, as I said, we think about it when there's an outbreak, that maybe the batch of the alcohol is contaminated with a multi-drug resistant organism. But usually, if it's produced properly from good companies, it should not happen. But we have reported multiple outbreaks due to local manufacturing of alcohol products that were defective, were contaminated.
Okay, I think the question is like, have you seen outbreaks that are due or that have been contributed to by resistance to alcohol and stuff like that? Alcohol works fine.
No. But usually the product gets contaminated.
Yeah.
But in the future, like, we worry about resistance to antibiotics now.
Yeah, طبعا احنا we always worry about disinfectants and antibiotics being sort of becoming useless because of the emerging resistance. We have not seen that. And I can recall we were invited to Oman because they had an outbreak of gram-negative bacilli among hospital patients, and basically the reason was contaminated alcohol products. So when we used the alcohol and the gel, it was very slimy. So we took swabs from them and they grew the same organisms. So it can happen.
Where was this happening?
In Oman. Yeah. Any other questions or comments?
Thank you, doctor.
واضح؟